Okay, and with that, I'll turn it over to Michelle and Sarah from the Community University Healthcare Center for Beyond the Hype, Early AI Governance and Implementation Lessons in Community Health.
Hi, everyone. You can go to the next slide. Yeah. So hi, everyone. My name is Michelle, and thank you all for joining us today. We really appreciate your time. I'm a nurse informaticist at CUHC, and CUHC stands for Community University Healthcare Center. Throughout this presentation, we'll be referring to it as CUHC, so just want you all to know what it stands for. Sarah, would you like to introduce yourself?
Yes, thank you so much. So I'm Sarah Zimbato Segura, or I go by Sarah Zimbato. I'm also working here at CUHC, is part of the nursing informatics team with Michelle, and just also highlighting that we are both EHR support analysts or ESAs, which we work on a team that manage and support our electronic health records. Next slide.
Yeah, you can skip to, I think, the next slide, please. So we want to tell you a little bit about CUHC and the history of CUHC. CUHC is a federally qualified healthcare center in the Phillips neighborhood of Minneapolis. There's a few unique factors that make about CUHC that we want to highlight. So it's one of just a handful of community health centers nationwide that have a co-applicant status with the university. Ours is with the University of Minnesota. And in addition to this, it's one of just a handful with this status as well as a land grant. So what this means is that we're a public institution and we have a mission to serve the state of Minnesota. So CUHC was started by two University of Minnesota pediatricians in 1966. You can see them here. And a little history about the neighborhood of Phillips. Construction of Interstate 35 in the late 1950s had a really detrimental effect on the neighborhood. Construction went right through the Southside neighborhood, which was a Black neighborhood, and displaced a lot of people and families and really isolated the neighborhood. In the 1970s and 80s, there was a really large influx of refugees who moved into the neighborhood, specifically Hmong, Vietnamese, Cambodian, Malaysian populations. And then later in the late 1980s, early 90s, there was an influx of Somali refugees into the neighborhood. And today the clinic still serves the community that lives here. And there are other communities throughout the Twin Cities that travel to CUHC to get their care. So you can go to the next slide, please. Sarah will take over.
Yes, thank you. So I want to recognize that many of you in the audience may work for or partner with a community health center or other safety net organization. We do want to provide some brief information about health centers to make sure everyone's on the same page as we share our journey and will reflect on throughout our presentation. So the first community health centers opened in 1965, and they were actually a demonstration project out of the Federal Office of Economic Opportunity, which at the time was the lead federal agency in President Lyndon Johnson's War on Poverty. Same time frame where other social programs like Medicaid, Medicare, SNAP, etc., were being stood up as well. Originally called neighborhood health centers, they were meant to be healthcare for the community in the community. And then in 1966, further legislation supported the creation of a national health center system. So as Michelle shared, CUHC was founded in 1966. So a fun fact, CUHC is Minnesota's first and oldest community health center. Today, community health centers are located in all 50 states, US territories, and Washington, D.C., serving both urban and rural communities at more than 17,000 delivery sites, which ultimately is creating the largest primary care network in the country. Next slide. So a common phrase about community health centers is if you've seen one community health center, you've seen one community health center. If you know, you know. What this means is we all are very unique in our own ways. So the neighborhoods that we serve here in CUHC are going to look very different than neighborhoods in rural Montana, California, Guam, you name it. But although we're unique in our own rights, there are key aspects that we all share. So, health centers provide comprehensive care in medically underserved areas. We're focused on reducing barriers to accessing that care. And we have income based sliding fee programs to provide services regardless of someone's ability to pay, which is like one of those barriers for consideration. We're community governed and are heavily regulated by the Health Resource Service Administration, also known as HRSA, which sets specific program requirements that each center must follow. Next slide. So, as I mentioned in the previous slide, community health centers are community governed. So, what does this mean? We are, well, our board members have to be at least 51% or more patients or first degree relatives of patients of the health center. So, really patient centered from our board governance. The board of directors provides oversight, governance on key functions of a health center, including like the finances, budget, strategic and quality plans, overarching policies such as care delivery, services, hours of operation. But the day to day is managed by the clinic. Next slide.
So a bit about CUHCC's mission and vision. The things I think I'd like to highlight most is our commitment to education and the fact that our mission revolves around the community that we serve. We can go to the next slide, please. And a bit about those communities. Oh, next slide. There we go. Thank you. So a bit about those communities. We've touched on some of this already. But to highlight a little bit more, our payer mix is heavily Medicaid and uninsured patients, and only about 9% of our patients have private commercial insurance. And language diversity is another piece that makes CUHCC unique. So the majority of our patients, 53%, prefer their care in a language other than English. Last year, we recorded 57 languages spoken, the top 3 being English, Spanish, and Somali, so just a ton of languages. And I realized I missed a slide, so can we go back to 6, please, Nikita? Thank you so much. Okay, so CUHCC employs about 145 staff, and last year we hosted 185 students and learners. So more students and learners than staff. In terms of patient volume, last year we saw about 12,000 unique patients through approximately 50,000 visits. We have an operating budget of 25 million, and our EHR is through Ocean Epic. And we do want to touch specifically on Ocean and talk a little bit about Ocean because it's a really big, part of our story. So Ocean is a non-profit vendor. I know some of you are going to know who they are, but just in case you don't, Ocean is a non-profit vendor who supports our version of Epic. They have one instance of Epic that's shared among many different organizations in the safety net and has key features that support community health centers, specifically like federal reporting that we're required to do. So this is an amazing thing for us. It's a way for safety net clinics like us to have access to Epic. But it is different than larger academic medical centers or big integrated healthcare systems that have their own instance of Epic. So we can go to slide 9, please. Sorry to make you jump around. Thank you. And to sort of get into the meat of our presentation, we just want to touch on the environment that we find ourselves in with AI. I'm sure you guys people here are experiencing this as well, but there seems to be a tool for every facet of healthcare. Our clinic is inundated with contacts from vendors pitching new tools. And while these tools are presented as something to help leverage resources and reduce cost, it's still to be seen if AI will actually increase or decrease the cost of care. We don't know yet. And will AI ultimately require more resources from each healthcare center? And all of this has changed so fast, just within a few years. Let me go to the next slide, please. I think you can, there's an issue one more time. Yeah. We keep going. There's a table that should pop up. There we go. Thank you. So we have vendor contacts from so many branches of healthcare, from rev cycle to documents and policy management. There are organizations that will help you with the legal process of implementing AI and even developing your own AI governance. OCHIN is launching new AI tools. Many are available now. There's many that are on the roadmap. Almost every time OCHIN has an enhancement or service pack that comes out, it includes a new AI tool option. On top of all that, the university has enterprise approved tools. These are tools that have a higher level of security, and they have expectations for our clinic to promote their use and to make sure that other tools aren't used. And so altogether, this just creates, it's a lot for a resource-stressed clinic to handle. You can go to the next, please. Perfect. So we all, I think, have feelings around this and we feel it, but I think it's worth mentioning specifically or saying it out loud. Why are we becoming AI ready? Like, what is the purpose of becoming AI ready? For us, it comes down to these main reasons, but this isn't an exhaustive list. But in terms of new skills, you see that we list patients first here. So new skills for patients, staff, and students. Patients need to be brought along in education along with our staff and students. They need to be educated, they need to be aware. We host a lot of providers, family practice residents, nurse practitioners, for example, and they also have expectations that these types of tools will be available for them to use. So just for the students coming in, we have to be ready for them as well. Many of our patients are already vulnerable to existing disparities and inequities, and we need to make sure that our use of AI doesn't exacerbate that. We have to make sure our patients' data is secure and that patients feel comfortable and knowledgeable about our use of AI. And these tools can't create extra burden for our staff. And we have to have some kind of process to track these tools, making sure we know what's on, what's off, and making sure the tools stay safe and effective. And I think the biggest thing is that we cannot ignore this. We have to take initiative in our own AI governance and testing. It's something that we have to do ourselves.
All right, so this is a snapshot of our digital timeline with some key information that I want to highlight across it. So in November of 2019, we went live on Ocean Epic, which was monumental for us. We had more reporting capabilities and system transparency within the first 30 to 60 days on Epic than we did in years on our previous system. In 2022, we hired our Chief Innovation and Strategy Officer. And something I want to note here is that we know not every organization has access to this type of leadership. Centers may need to build capacity in their executive teams to support AI implementation and other innovation. In 2023, we introduced the HIMSS maturity models to benchmark our organizational use of technology. We also participated in the inaugural cohort for the NAC Abbott-sponsored incubator project, where we had to pitch a solution for improving our patients' digital health literacy. The Health AI Partnership Opportunity inaugural cohort as well opened in 2024, which has led to us working on our governance and optimization with OCHIN. As you can see here too, in January, our dental department joined us on Epic, which also further enhanced our operations. And something I want to point out that you probably heard me say the twice is that we were part of 2 different inaugural or first time around cohorts. We're always looking for opportunities to gain organizational development that aligns with our strategic initiatives. And the incubator and HAIP have been examples of those amazing opportunities that have supported us in this work. Next slide, please. So I want to start to transition us and talk about our journey through HAIP. And laying out the rest of the presentation here. So the folks that you see on the screen, which I'll start and I'll go clockwise, is and has been our initial project team when we applied to the HIP practice network. So Michelle has been our project lead. I served as the clinical champion role. And then we have Young, who is one of our front desk supervisors and long-term CMA here at CUHC. And he joined the project since our initial plan, which you'll learn a little bit about, was to work on a solution to reduce no-shows. Dr. Dovedi, our CEO and CMO, and huge supporter of our digital transformation. And then in the middle on the bottom, we have Dr. Steve Johnson, who's an assistant professor in the Institute for Health Informatics and associate director of CTSI Health Informatics program at the University of Minnesota, has been volunteering his time as a data scientist to help us through this process. And Eric Maurer, who is our CISO, as I mentioned in the previous slide. Next slide. All right. So we'll go a little bit through our initial proposal. So what we started with, no-shows are a problem for our patients, our providers, and for our financial stability. So when we talked about health centers, providing income-based sliding fee discount programs to reduce total cost of care, we are not free clinics, and we do have to find sustainable ways to provide this care to our patients. We have multiple funding streams, but we do also have to think about being financially responsible. We were interested initially in implementing Epic's risk of patient no-show model, which we thought at the time of application was available to us. And through our process learned that version 1 had been sunset and version 2 was not yet validated by OCHIN and ready for deployment to the individual clinics on the OCHIN collaborative. One of our first discovery calls, which was pretty fun and pretty amazing, was with HIP, and it included a deeper dive into really kind of like thinking on the why and what will you do with the information gained from the analytic. And with the help from the HIP team, we determined we would take patient-friendly approaches for doing like outreach rather than double booking. Next slide. So as I mentioned, kind of early on, maybe, I don't know, 3 to 4 months into the project, it was apparent we were not going to be able to at least start with our initial proposal. And that delay on the predictive model was actually a blessing in disguise because it allowed us to take a few steps back, pivot our work to focus on governance. So all of the learning process, or this is really all part of the learning process when considering new tools, products, etc. And we additionally learned to not rush in to try something, to be a little bit more intentional. I think there was the initial pressure to be like, well, this is what we submitted, this is what we have to work on, when in fact, oh, we learned something new and now we need to shift because we really wanted to take full advantage of the resources available to us during the cohort time. And I wanted to just also kind of mention our mentors, Dr. Yasser Terabici with Metro Health and the UCSF team. We worked alongside with them. They shared their experiences with operationalizing no-show analytics in patient-positive ways. And through all of this was just learning and building skills. Next slide.
So as Sarah, can you guys hear me? As Sarah mentioned, we hit a roadblock, had to pivot, and it was a silver lining because it enabled us to focus on building our governance. So we had to figure out where to start, and we knew that we wanted our governance process to be as transparent as possible. So we started by polling the clinic to ask how they're feeling about AI. And Nikki, I think if you do one more, there's a table that will show up, or a legend. Perfect. So, and also in connecting with the team and soliciting feedback and engagement, we hoped it would open the door for navigating successful change management. When the team feels like they're part of the journey, you can identify those who are ready for adoption, or in piloting, which can be super powerful when we're ready to bring others into the tool or in this new process. It's a new process for us. So if you look at the red and blue, you can see we were surprised that there was a lot of alignment around feeling generally positive with providers feeling maybe a little bit more skeptical. So at least 50% other than providers feeling somewhat positive or very positive or neutral. There weren't too many people that were feeling very concerned about AI. So that was interesting to us. Go to the next slide. What also surprised us was that there were a lot of commonalities between stakeholders in terms of specific things people were excited and concerned about. So everyone was excited about making routine tasks automated, and everyone was concerned about adverse outcomes and the security of patient data. Next slide, please. So then once we got that feedback, we decided to start outlining our governance framework. So this framework includes existing and evolving IT governance. It includes rapidly moving state and federal regulations, and it represents just generally a revolving structure. This is all very dynamic. The board sets the mission, vision, and values. And as a reminder, our board, our patients are first degree relatives of patients, and operations are led by our CEO. So together, the board and the CEO tasked us with coming up with the community AI framework. The specific expectations for this was for us to maximize the benefits and minimize the risks of AI. So benefits specifically being equitable and valuable deployment and having a process of maintaining AI. Risks specifically being bias, cybersecurity, and just general harm. This is also the place that I'd like to mention that we are planning much more patient engagement in the future, for example, with disclosures, patient advisory conversations, things like that. We needed to get some relatively low risk pilots under our belt because we didn't want to present patients with hypotheticals. We wanted to present them with concrete examples in our learnings. So just wanted to mention that. Next slide, please. So then we went to develop our actual process. So we had to figure out how to actually operationalize this framework while making sure that we address the concerns of our stakeholders. And I want to say that this is not always a clean process. Sometimes it changes, things aren't always in this order. And it's also important to mention that key pieces of this process are in place, not only just for AI, but for any clinical decision support changes as well. So for example, if a department proposes a change to the EHR, it also goes through most of this process. AI has some key features, and I'll get into those. But what we start with is a need, a request. Our requests are brought in through our ticketing system, and we always Sarah and I always have to gather more information about the request. So what we often need to learn more about is the problem that's trying to be solved. We're trying to figure out, is the juice worth the squeeze? Again, we're resource strapped, so we need to know that. We almost always need to know what current workflows are, what teams are involved, and what expectations are of the tool for that team. Like, what are they looking to get out of the tool? In terms of risk assessment, in order to mitigate risk, we're starting by considering Ocean Epic integrated applications. If it isn't integrated into Ocean Epic, we have to follow a much more stringent risk assessment and approval. And then we present our findings. So we go through this process and we present our findings at what we call CDS, or clinical decision support. CDS right now is part of our clinical committee. It's like, again, we do as much as we can in the little time we have. So CDS right now is part of our clinical committee, but we are looking to separate this into its own meeting in the future. If we're working with a third-party vendor, our Office of General Counsel generally handles the contracting portion. And then when we get to the piloting stage, we really focus on human in the loop. So for example, figuring out how feedback of the quality of the output of a tool is provided to Ocean, for example, or making sure that users are reviewing the output generated by the tool. And I'll give more examples of this later in the presentation. So we can move to the next slide, please. So like I said, our process begins with our ticketing system. The ticketing system is something that was already in place for our data quality and ESA requests, and also for our research steering committee, and it works really well, so we extended it to AI. We built this all ourselves in Smartsheet. For those of you that don't know or don't use it, Smartsheet is a very low-cost application to stand up. Excuse me. So first, users fill out what you're seeing here. It's an ESA request ticket with the request to look into the tool, for example, and some basic information. Once Sarah and I identify the ticket as an AI or CDS request, then we move that request to a separate sheet, which is shown next. And here we can just see outstanding tickets and the status of the ticket. And this is the point where Sarah and I will be like, oh, we need more information, which we always do. And so then we'll reach out to gather more information. Go to the next slide, please. And then, yeah. So this is what I'm talking about when I say that we have specific things for AI that are separate from CDS. So specifically, AI has an implementation form. This is a working document that isn't complete until either the AI tool has been rolled out and it's operational in the clinic, or it's decided that the tool isn't going to be implemented. One of the first things on this form is to choose metrics to measure the model performance. So as you can see here, and I'll talk about this in more detail, for this particular tool, we chose three. I'll talk about them in more detail. And we also take time during this process to figure out what changes would need to be made to existing workflows, and also figure out any privacy or security concerns. And once we get to that point, that's when we present to CDS and we present them with what we found, and they say that they either want us to go ahead or not to start a pilot. Once the steps of the pilot are laid out and those are completed, at the end of the pilot, we again present our findings to clinical committee to decide whether the tool should actually be implemented and operationalized in our clinic. And then we go through the rollout process. What's up right now is just a dashboard that shows, it's just another way for Sarah and I to keep track of what's going on. So there's, like I said, there's a lot going on. So we need multiple tools to kind of keep us on track. Okay, next slide, please. So to get into more specifics, the first AI pilot, once we were like, we need concrete examples, we need to have actually like done something so that we can learn from it and bring that into our governance. So what we chose is the automated response technology in basket tool. What this does is when patients send a medical advice question through MyChart, that message gets sent to the nurses pool. And this tool will generate an AI response. So for example, a patient might, who had come in for like knee pain might say, my knee pain's back, what can I do? And the draft might say something like, elevate it and take some Tylenol, something like that. It's just, it gives nurses, it's supposed to save them from, having to write out everything all the time. So we started with a small pilot group, a really small pilot group. It was 3 of our nurses, our nurse supervisor and nurse lead, and then another nurse. It was a 2-week pilot. And what we asked them was for feedback on every draft response. So when a draft was available, we asked them to give feedback on every one. And what we tracked, and this was available through Ocean Epic in a dashboard, but we tracked drafts not available. So sometimes the tool would just be like, I don't know what to do with this. So we tracked that. We tracked the thumbs up and thumbs down that the nurses gave each message. And we also tracked the percentage of drafts used. So how many drafts were ultimately included in a message back to a patient. We learned a lot from this, even this small pilot, we learned so much. The biggest piece was that we really needed to do more robust education on the tool, both ourselves, like educating ourselves on the tool, and doing forward education for the users before they started using the tool. So, for example, one of the biggest complaints from our nurses was that the messages, well, first of all, anyway, they said that the messages were very curt. Like they didn't say hello, they didn't say goodbye. They just, so for example, it would say something like, elevate your knee, take Tylenol, and that was it. And they're like, it's so rude. If I sent this to a patient, they would get really mad. Like, it's, And Sarah did some digging and found out that that's actually built into the training model, and it's to keep the human in the loop. It's so that the person has to interact with the tool. And what we learned is like, we need to know those nuances so that we can train our users that that's to be expected, and then they wouldn't have expectations that they shouldn't for the tool. We also found out that we really need to do a longer trial period. 2 weeks was too short. And it just sort of solidified our need and what we needed for our governance as well. Next slide, please. So we tried to take a lot of learnings and bring it into our current project. So first, I just want to say that when the tool becomes available, we're still fully planning on pursuing Epic's no-show tool. We got such great insight from Yasser at Metro Health, as Sarah mentioned, one of our mentors, and it's on Ocean's roadmap, and we're fully planning on pursuing that when it becomes available. Right now, we're in the middle of our ambient scribe pilot, and we've been much more forward-facing in terms of educating providers before they start to use it. So it's a longer pilot. We're planning for 6 weeks. We have a designated provider champion who will also be a resource for other providers in the pilot. So we've given them earlier access to the tool so that they're not using with PHI right now, but testing it, doing mock encounters so that they can share their learnings from a provider perspective. It's one of our physicians that's doing this for us. Ocean came out with a slew of new billing AI tools, and our billing ESA, Jenny, is heading implementation of those tools. And this is an example of us trying to bring others along in governance and trying to bring everyone along and not just having Sarah and I heading up everything. We're also updating the clinic on compliance with AI tools. So this is taking a lot of teaming with our director of compliance and HIPCO, which stands for our Health Information and Compliance Office. And in general, there's just ongoing, again, this process is super dynamic. So there's ongoing development and optimization at all times.
All right. So I want to recognize that we've covered a lot of information in a short period of time. So we had some history, you learned a little bit about us. Michelle gave some great insight to our process and kind of where we're at today. So let's reflect on some core takeaways to keep in mind no matter where you might be in your organization's AI journey. So, local validation requires resources. So, time, money, people. FQs have an astonishing nimbleness in finding ways to be innovative within their means. However, it can often feel like we're being asked to do more with the same or less. So, looking for programs and resources that might be available to tap into. So, HAIP, trusted vendors, and other partners that you can connect with. Also, finding a structure that works for your organization. As Michelle shared, we mirrored some of our current structure from our governance work that we've done in other areas at the clinic. to build efficiency with the process. So we're not trying to add more, but we're trying to integrate. So it just seems like it's another part of the process. And because, especially right now, it's the same people and teams who are doing the work across all of the projects and initiatives. Not everything will go as planned. Reflect on these experiences and gather what you learn for the next round. It is okay to be working on governance at the same time you're trialing things out. You do not need to have everything in order to start. But think about some of the most important things like risk assessment, managing, expectations, and plan to bring your teams along with you. Engage your stakeholders and your community. We intentionally started with low risk projects. Find places and spaces to share. See some, do some, teach some, which is why we're here today, and why we participate in some of the things that we do. It's core to CUHC's mission, vision, and values. Sometimes when you're doing the work, it can feel like you're not making as much progress as quickly as you'd like. So one of the things would be to really take the time to look back and see how far you've come. So it's been so valuable to actually close out from our practice network cohort and to be here to present, because it made us sit and reflect on how much we've accomplished in the last 15 months. FQs can do this work, and we do actually really need to have a seat on the front lines of doing the work as well. Because as I mentioned previously, we're the largest primary care network in the country. We do want to end by thanking the HAIP team, including the core and mentor sites. So Metro Health, UCSF, Mayo, Epic, Ocean, Centers for Care Innovation, and many others. So thank you all.
Thank you so much. I know we already have a few questions in the chat. This has been a fantastic presentation. I'll give folks a few minutes to see if anyone wants to kind of raise their hand and unmute, or if not, we'll start going through questions in the chat. Teresa, I'm not sure how you pronounce it, but go ahead. Don't think we can hear you.
So sorry, can you hear me now? I was just talking and apparently the microphone was not connected. Okay, well, thank you so much. This is super interesting for me because we are currently forming our governance council. We've been following the framework on the vendor domains we're supposed to be looking at. And I love the way that you got your team kind of put the process you were following. I just have questions on. We're told that we need to look into, we're recommended, sorry, not told, right? We're recommended that we need to look into different metrics and look out for bias and make sure that the AI tools we bring in are fair and equitable. How did you design your own metrics? Did you design your own metrics? Or I really love the way that you also work with physicians and nurses and everyone to make sure that the recommendations that you were receiving from the tools were accurate. But my question is, how do you know, is there a way that you could say, okay, this system is 90% free of bias? Or how did you shape those variables that you measure? Because I think that's where I'm currently stuck in how we're assessing the different vendors that pitch to us.
Yeah. So this is such an important question, really good question. And the answer is not straightforward. So in terms of the metrics that we chose for the ART in basket, that was an Ocean Epic integrated tool. So they had a dashboard available to us to track things. So part of it was tracked by them. And so we chose the ones that it included more metrics than that, but we chose the ones that we thought were most applicable. So for example, which drafts were actually used, what percentage, the numbers of thumbs up, thumbs down. And again, the nurse was supposed to put a thumbs up or thumbs down for every message that was available. And I can't even right now. remember the third one. But anyway, all of those were part of our dashboard. Now, I think it's important to make a distinction between the performance of the tool and tracking bias. Now, I mean, it's all kind of one and the same, but the metrics that we chose were to track how well the tool was working. But to your point, to your question about tracking bias and things like that, that's been a harder nut for us to crack. We're working really hard with Ocean and with Epic to work with a tool that's called the seismometer, and we have which does that for you. It will show you how, first of all, how well the tool works for you. It's an Epic application, so it works with Epic tools, and you need a data scientist, which we have through Steve Johnson. But it will, and I'm probably, just any data science people here are probably like, oh my gosh, I'm butchering this. But basically, it shows you how well the tool is working, like how well its predictions are working, and it also, you can break it down by demographic. I don't think it and maybe Eric wants to chime in. I don't think it works for generative AI. So it works for predictive AI. I don't think it works for generative AI. And so that's a harder thing to figure out. Like, how do you track that this isn't perpetuating harm? And we're working on that. Sarah, do you want to say anything?
Yeah, I think I'll add, and one of the things that Michelle just said is kind of key. And this was one of the conversations we had with our mentor sites as well, is, kind of on that maybe lower risk end of trying something, your generative information versus predictive. Are you looking at something you need to take action on that might exclude or include someone you did or didn't mean to? Or is it something that's just giving you more information and somebody has to use their own kind of clinical expertise or information to take it from there? So I think it really does come down to like what purpose is the tool serving for you? So like for the ART, it's just taking information in the message and it's either giving you a draft or not giving you a draft. And then the nurse then has to decide, oh, I like this and I want to use this and it seems clinically appropriate and I'll smith it up whatever way I want. Or, it doesn't really meet what I need or it didn't give me anything, so I have to write it anyways. And so it's just a tool to help support the care, but it's ultimately, responsible on the clinician to validate and move on from there. Um, and there's other things, and what we mentioned too is like the version, right? Version 1, there were concerns around bias, and so that's why Epic took it back and has been working on better models from the predictive analytics side of things, so that you're not missing out on people, or you might read between the lines and see some additional things that you need to make sure you're not missing. But as Michelle said, like it is something that we have to kind of keep in our mind and evaluate. And there's not really like a perfect algorithm to say this, that, or the other, but just kind of like proceeding with caution and walking that path.
Absolutely. I love it so much. Gathering feedback from the people that are using the tools and making sure that we understand the purpose of the tool.
Yeah.
This will help validate its usage. Awesome. Thank you very much. I'll probably
Yep.
reach out with more questions later.
Great.
Any other folks want to come off mute and ask questions? Okay, I'll pull one from the chat. How would you say CUHCC is using AI more generally, so not necessarily specific to a use case, like reducing no-shows? There is a significant opportunity for everyone in the delivery system to amplify their impact with even off-the-shelf solutions, but everyone this person has spoken to in FQHC spaces haven't necessarily realized value yet from all-purpose AI tools. So curious about your thoughts on general approach and strategy.
So, I mean, I think that's generally what we've been maybe trying to present today is on our slide where we kind of listed the overload, right? So much information coming in and, everyone promising to solve your problems, that feeling of if it sounds too good to be true, it might be too good to be true. And so our approach is to look at anything, whether it's within the health record or outside of the health record, and take a similar approach. I think Eric mentioned it earlier in one of the questions of evaluating the vendor. Does it align with the work that we're doing, our, mission, vision, values? We have that co-applicant status with the University of Minnesota. So we have things that have to go through a much more stringent, legal contracting risk assessment process. In regards to that. And the university is doing a little bit of their own work on some of those more enterprise level things. So we mentioned Gemini, for example. That is, kind of like your Chat GPT. It's the Google version, if you haven't heard of it. The university has laid out very specific rules and policies on when to use it, how to use it. And we're part of the university, but we are our own entities. So we take that information and we communicate it out to our teams to say, you can use it for this, you can't use it for that. But here's some ideas and thoughts on where you could try it out, and see how it works. Even though it's not integrated into like a health record, and it's really taking our teams along with it to say what's appropriate when, what are some use cases once we've gone through that kind of vetting process, on how we're going to use it. So that's, ultimately what our team is trying to do is there are all these tools that are available or being pushed out. They reach out, every provider who or somebody who goes to a conference, there's another tool or things that get people's minds going. So it's just that framework. Like how do you get the information in? How do you disseminate it? What are the expectations? We're still working on like our own just kind of procedure around AI and listing it out and being as clear as we can to our teams. But we're still in that just very kind of early stages at this point. That answer your question?
Michelle, anything you want to add?
I guess when I think about AI at CUHC, I think that we are taking what I would call a conservative approach, and there aren't a lot of there. We don't have right now, I don't think, any AI tools integrated because we haven't found one compelling enough where like it'll solve a big problem. Now I think that that's going to change with our ambient scribe. But again, we're trying to take a problems first approach. Like what problem is this going to solve? And so with that approach, you don't just turn on every AI tool. You really do a lot of scrutinizing. Sarah and I are just like, studying these things all day. And I mean, I'm being a little bit hyperbolic, but yeah, it's that problems first approach. You really want to make sure you fully understand the problem that this will help.
Thank you both. And I'll go to Kay Coleman that has their hand raised.
Hi there, my name is Katie Coleman, calling from Seattle. Thank you so much for a great presentation. I love your problem first approach, and the sophistication of the way that you're doing sense making before bringing in these tools. It's really inspiring. I am wondering, I've worked with federally qualified health centers for a long time, and what strikes me about the implementation of AI is that a lot of the barrier is implementation barriers that are similar to the same barriers we saw when we were working with practices to implement the chronic care model or implement the patient-centered medical home or implement, fill in the blank integrated behavioral health or, collaborative care model. And so when you talk about some of the barriers, you had a beautiful slide earlier about some of the barriers. I guess I'm wondering if you could reflect on two things. One is there anything really different about AI, or is it really just another tool that is facing similar implementation challenges for like any other innovation we've been working on for 20 years. And I am asking that deliberately in a provocative way. And then I also wonder if you could share a little bit about your reflection on what are the tools that you think, you mentioned ambient scribe, as having a potential to actually meaningfully solve a problem that matters to your patients. So those two questions, thanks.
Yeah. So to answer your question, and I hope I answer it correctly, I do think AI is different. Well, first of all, I just want to say, I completely agree with you that having to figure out a way to deal with AI is similar to things in the past. Like, for example, implementing the electronic healthcare record, right? And I think that we in general, right, are lacking the governance that we had during EHR. Eric always talks about how we need sort of local offices to help us with AI. Like for example, to have a data scientist available for a whole community, like we had with high tech with implementing EHR. So resources at a community level to help the safety net deal with this. I do think AI is different in that I think it, who knows, but I think it's a humongous technological shift that's going to change the way things go in life. There's a huge economic component of it. It's inundating not just our work but our lives. We'll see how it goes. I'm pretty nervous about it, but I do think that it is different in that case. Like it's I don't know that we've seen something that has had such a broad reach for everybody everywhere. Kind of. That's my opinion. It's my opinion. And remind me of the second part of the question, because I did have something to say about that too. Please.
Well, just the idea of taking a problem, you called it a problem first approach. Like when you obviously have been looking at a lot of different tools and things, like what
right.
is meaningfully helpful in this overflow?
So for us, and again, this is where our unique clinic comes into play. So this answer I think will be different for people. For us, ambient scribe, so clinician burnout. Our clinicians work so hard; they see so many patients during a day. Clinician burnout, but for us, interpreting, we spend like $1 million a year on interpreting services, and some of our patients we can't find interpreters for. We have Mandingo speaking patients that sometimes speak a really particular dialect, and we maybe find a Mandingo speaking interpreter, and they don't speak their dialect, and then it's so hard to give those people the care that they deserve. So and then with insurance, if Young was here, he would talk about insurance and how some tool that could be really dynamic in searching for insurances that people might be qualified for. So, because right now it's this extremely manual process going from system to system to system, putting in the information, looking at it. So those are the ones that came to my mind.
I'll add maybe a little bit more to that too, is like things that we, taking a step back as this, a community health center, cost is a huge driver in a lot of these tools. So things that are available to us that are already integrated or already part of our enterprise or have been vetted, by the university or as part of being our EHR, those are the things that we really have to be more in sync with, because reality is we can't always afford the fancy bells and whistles, right? So a vendor who can perform at equal to or greater than at a lower cost and more securely, combination of things we have to evaluate, that's going to be maybe where we lean toward, even if it means giving up, maybe other pieces of it. And the reality of like maintaining clinicians and staff at our health centers, right? Like the big health centers have some of these fancier bells and whistles, and they may provide it at no no cost or at low cost. And so it does kind of become a little bit of the keeping up with the Joneses, and being able to offer at least something to our teams, that that we're making an effort, we're engaging them, and they have a say in, like, maybe it isn't something that I thought I wanted, but they got to try it. At least doing that piece of it, and evaluating and such. So a lot of factors that go into decisions. Free isn't always best, but accessible and financially responsible, and that you're going to in some way get a return on the investment. As we mentioned earlier, the goal, like, even of just reducing no shows, the solution wasn't that, like, well, if we find out this information, we're just going to double book in those slots. That was not our intention. We had other thoughts, or frameworks that we still are going to have to figure out once it's available to us. But the ultimate goal is not to be adding more, but finding a better balance and outreach. Thanks.
Awesome. Thank you so much. I think we're just about at time, so I'm going to hand it over to the CUHC team to do a quick closeout. But thank you all for your questions. If there are additional ones that we didn't get to, we can email them to the speakers, so feel free to send those.